Hi, everyone. Good morning and afternoon. Welcome to today's webinar, Mitigating Safety and Risk for Children Affected by Parental Substance Use Disorders Involved in the Child Welfare System, brought to you by the National Center on Substance Abuse and Child Welfare. And a big thank you to everyone taking the time out of your day to join us. We're really delighted to have you here. The National Center on Substance Abuse and Child Welfare is a collaboration at the federal level between the Administration for Children and Families and the Substance Abuse and Mental Health Services Administration. The National Center has operated since 2002 and provides information, consultation, training, and technical assistance to child welfare, substance use disorder treatment, court personnel, and other systems serving families. Several of our resources will be highlighted during the presentation, and we hope you will have a visit our website for more information. And I'd like to now introduce today's presenters. Kim Bishop, who is the Deputy Program Director for Collaborative Technical Assistance for Children and Family Futures, or CFF, which holds the contract for the National Center on Substance Abuse and Child Welfare. Prior to coming to CFF, Kim worked in substance use disorder treatment and early intervention as a clinical social worker before serving as Director of Substance Abuse for the Massachusetts Department of Children and Families, or DCF, for 17 years. There, she worked on policy and program development for families in the child welfare system affected by parental substance use. She also acted as DCF's primary liaison for substance use interagency initiatives with sister state agencies, local communities, and providers. And also presenting today is Elizabeth Bullock, a Senior Program Associate for CFF. Elizabeth works on the National Center contract and with the Sobriety Treatment and Recovery Team, or START, at CFF. In this capacity, she provides technical assistance to state and county child welfare jurisdictions for the implementation of the START model. Ms. Bullock gained direct service and leadership experience through her work with the Indiana Department of Child Services as a family case manager, supervisor, and local office director. She has prior experience working with survivors of intimate partner violence and sexual assault and has worked in the field of crisis intervention for most of her career. And with that, I'm going to pass this over now to Kim to move us along. Thanks, everyone.
Thank you, Some. It's so great to be here with so many people joining from across the country. Today, we're going to talk about how child welfare assesses parental substance use disorder and how screening, observation of the parent's behavior and physical environment, as well as connection with provider, informs child welfare's understanding of safety and risk. We'll look at opportunities where systems and providers can come together and partner with child welfare on planning for safety with families. We'll end today talking about different collaborative opportunities that support overall family well-being. The Department of Health and Human Services Administration for Children and Families, the Children's Bureau, is responsible for the implementation and management of the Adoption and Foster Care Analysis and Reporting System, also known as AFCARS. State and tribal Title IV-E agencies are required to report case-level information on all children in foster care and children who have been adopted with Title IV-E agency involvement. This slide shows the prevalence of children in out-of-home care during the year in which parental alcohol or drug abuse was identified as a condition of removal. You'll see that since 2000, there's been a steady increase of children in out-of-home care with parental alcohol and drug use as a condition of removal. Although 39% in 2020 is about twice as what it was 20 years ago, that doesn't necessarily mean the problem is twice as big today, as we have to look at how we collect and report data. The numbers actually may be far greater. Being able to frame and understand the scope of parental alcohol or drug use in the child welfare system is important for all of us on this webinar, as we can use this data to bring systems together and increase resources and supports that benefit families. Next, let's look at this information by state and see if it resonates with what you're seeing in your community. In 2020, there was an average of 632,000 children in out-of-home care and over 245,000 with parental alcohol or drug use as an identified condition of removal. Take a look at your state and use the key on the right-hand side of the slide to see where your state falls. The percentage may not seem right and may even seem low to what you're experiencing in your state. When we present this information across the country, we almost always hear that this doesn't seem accurate to what people are seeing day to day in their communities. We know there are challenges with data collection. There are differences in how states identify parental substance use. Some states have universal screening and others do not. There's variation in data systems with how the data is entered and how parental alcohol or drug use is captured in data systems. For instance, neglect is one category that may be selected for a range of reasons, including parental alcohol and drug use. Point in time in which alcohol or drug use is identified and then entered into the data system can also account for some differences. For example, a parent's alcohol or drug use may not be identified until later in the case, until after the data was already inputted in the system. Often at the local level, multiple child abuse and neglect reasons are reported, and sometimes only the primary reason is reported to the federal system. No matter your role, it's important to be part of the conversation on how we're capturing the need in our community. This is something to talk to your partners about when you come together and talk more about your collaboration. On the next slide, we're going to look at this same data, but broken down by age. We have seen a rise in the number of young children entering out-of-home care. You'll see on the left-hand side of the slide the heat map that shows the same information we just looked at, but for children who are entering out-of-home care under the age of 1. On the right-hand slide is the information for children who are over the age of 1. Take a moment and find your state on both maps to see where you fall. For children under the age of 1, we see states that are shaded in dark blue that are higher than 60% where alcohol or drug use was a condition of removal. Of that 60%, we know that there are 6 states that are higher than even 70% with parent alcohol or drug use as a condition for removal. As we're talking about safety and risk for children today, this slide helps us understand the number of children under the age of 1 entering out-of-home care. For the youngest children, we know that concerns about their risk is higher as they're often not visible in the community, they're heavily dependent on their caregiver to meet all of their needs, and they have high needs due to their age and development. But this isn't just about young children. This data and feedback from states and communities we work with tells us the number of families involved in child welfare where there is parental substance use is significant. It's why you are all here today, and it's also why the National Center developed some new resources and training. One of our newest resources is the Child Welfare Practice Tip Series. The goal of this tip series is for child welfare professionals to learn more about substance use disorder. In 2019, the National Center developed the first 3 tip sheets in this series focused on understanding substance use disorder, engagement of families, and screening and assessment. This past year, we updated those tip sheets and with additional information and added 2 new tip series on identifying safety and protective capacities and planning for safety for parental substance use disorder and child welfare involvement. We're dropping a link to this tip series in the chat now, and we encourage you to use this resource with your staff and your partners. As a companion to the newest tip series, we produced a new video series on child safety and risk factors related to parental substance use disorder. These hour-long videos focus on engagement and safety decision-making and planning for safety when parental substance use disorders are present in the family. We're dropping links to these videos in the chat now for your reference. During the webinar today, we'll feature several clips from the video series.
Thank you, Kim. So to set the context for why it's important to recognize and distinguish between safety and risk factors, let's begin by listening to this clip from the first video in our series on the need to do better for families. So as you listen to this, think about your role with families as a treatment provider, a community partner, a court representative, a child welfare worker, or a leader in the field of human services.
Child welfare workers, courts, substance use disorder treatment providers, and community partners need to work together to address parent substance use disorders, to prevent removal, and provide services to support child permanency with their families. The process of engaging and retaining parents with substance use disorders in treatment and moving from treatment to lifelong recovery is multifaceted and complex. This process requires input and services from a variety of providers, the Child Welfare Agency, and the courts. Coordination by professionals across these disciplines will help parents navigate the road to sustained recovery. Many of the children in out-of-home care have a parent that uses drugs and alcohol. We know that these children often stay in foster care longer and have a lower likelihood of successful reunification. But this isn't one system's responsibility. Coordination and collaboration between systems serving families improves outcomes for children and families.
So take a minute to think about what you're currently doing in your agency to improve or sustain collaboration between all systems that serve families, and think about what you can do to move this needle forward. As professionals, we come into this work with a range of values, beliefs, and experiences, as well as education, in order to create a culture that supports and treats families affected by substance use disorder, which is commonly referred to as SUD. We'll need to consider how we're discussing, portraying, and responding to SUDs across all systems. Through research over the years, we've learned that an SUD is a disease and it should be treated as one. The American Society on Addiction Medicine, or ASAM, defines addiction as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behavior that becomes compulsive and often continues despite harmful consequences. ASAM goes on to state that prevention efforts and treatment approaches for addiction are generally just as successful as those for other chronic diseases. So when SUDs are treated as a disease, parents are screened for substance use and they're referred for an SUD assessment to determine the diagnosis and treatment recommendations, including the most appropriate level of care. It's also important to ensure treatment services are culturally responsive to individual and family needs. There's no one size fits all for treatment and child welfare services. So when we treat SUDs as a disease, we understand the components of quality treatment. We understand the importance of timely access to quality treatment. We understand our role in supporting, engaging, and encouraging parents to attend SUD treatment. And we understand reality-based statistics on recovery and return to use. So how do we begin this work in recognizing SUDs as a disease? A good first step is to reduce stigma around SUDs in our profession and in the community. It's well known that stigma disproportionately influences health outcomes and mental well-being. That fear of being judged or discriminated against can prevent people with SUDs or those who are at risk for developing an SUD from entering treatment, staying in treatment, and completing treatment. So this means it's important that we understand how each system uses language when they talk about SUDs and that they consider how to integrate language that isn't stigmatizing. Research has shown us that the language we use to describe an SUD can either perpetuate the stereotypes and bias that exists and impact treatment someone receives, or it can help engage someone into treatment and facilitate supportive professional relationships. So the words that we use really matter. Take a look at this list and think about the language that you use or the language you hear other professionals use. The column on the left lists words that we define as identity-first language. These are words that define the person as the disease, and they increase stigma. So consider the word clean and dirty drug screens. What does that imply about the individual? Does it mean that they're dirty? So the column on the right lists words that are person first, and these are words that talk about the person without defining them by their condition. Person first language gives people the dignity and the respect that we afford others. So instead of saying clean and dirty drug screens, consider the words positive or negative for substances. This is clear, it's non-stigmatizing, and it speaks to the direct facts of whether a person tested positive for a very specific substance during a specific period of time. How about the words hard to place kids? Children with mental health, trauma, or behavioral challenges often linger in the child welfare system, and it can be difficult for child welfare to find appropriate placement that meets their needs. These children often move from foster home to foster home, experiencing recurring trauma. So the term hard to place kids implies that the child's situation is their own fault. The alternative language, children affected by trauma, honors the experiences of the child, but it doesn't define them by those experiences. So let's look at the word drug addicted baby. Are babies really born addicted? No. So what we've really learned over the last several decades is that addiction is characterized by tolerance and cravings, and babies don't have cravings. They may experience exposure prenatally, they may have a physical dependency, but they're not addicted. So an alternative word for drug addicted baby is infant prenatally exposed to substances. So I'm sure that everyone can think of numerous other examples of language that you or those around you have used that might increase stigma. So think about how your own language and the language that you hear in your offices affects engagement. What can you do to change that language so it's person first? And how might this differ if you're working with colleagues, with families, or with community partners? If you're interested in more information about stigma, the National Center on Substance Abuse and Child Welfare has developed a stigma brief, which we will drop in the chat for you. So as we roll out these new resources, the information we're presented is informed by best practice and our decades-long work with states and communities across the country on how best to engage families. In treatment, courts, and child welfare, we often work with families that don't necessarily want to be working with us. And that's why genuine engagement is so important to our work. Engagement helps paint a fuller picture of what a family is dealing with, and engagement is key to gathering thorough information, which helps inform case and treatment decisions. Studies show that individuals with substance use and mental health disorders who are members of racial, ethnic, and other minority groups are less likely than their white majority heteronormative counterparts to receive appropriate diagnosis, enter and remain in and complete treatment, and receive adequate care. They also report lower satisfaction with treatment. So there are a lot of different reasons why these communities or ethnic groups are less likely to engage in complete treatment, but biases within our systems and failure to provide culturally and linguistically competent treatment are several of the primary reasons. So when we develop plans with families, it's important to always consider how to make use of the family's culture and their natural supports. Remember that families are experts on their own lives, and part of our job is to honor those experiences. To develop those culturally relevant case plans and identify appropriate services, child welfare, the courts, treatment, and other professionals need to understand how culture plays out primarily within the family. Therefore, in your work to help families safely raise their children, it's important to learn about their culture, and that includes their beliefs, their traditions, and their values. We all bring our own individual and organizational cultures to our work. So think about and understand how your own agency's culture, as well as the influences of your personal culture, affect your work. Successful work with families takes place when agencies have a strong organizational culture and they support strength-based practice. So once we've learned about a family's culture and we understand the culture of our own organization, we can use beliefs, traditions, and values that are important to families as a starting point or those building blocks for interventions. Likewise, if safety is maintained, be careful not to devise strategies or interventions that conflict with the family's culture. That conflict can greatly decrease your effectiveness. So when does engagement begin? Engagement starts at our very first contact with families. So once a referral is made to child welfare or a provider has been identified to work with the family, engagement begins. So we'll begin by assessing how do we build trust with the parents? Consider how to maybe create a safe space for them. Perhaps it's using reflective listening and talking through their hesitations and their fears to mitigate that disengagement. Are there immediate needs you can fulfill to help the family see you as that partner? Can your agency help with monetary needs like bus passes or rental assistance as an avenue to build trust and to help families see you as an ally? Does your role include helping the family identify childcare options to reduce those barriers to treatment entry? It's not unlikely that parents will be hesitant to work with child welfare or other systems. There's a lot of fear of the unknown and corresponding stigma associated with systems. So being able to explain your role will begin to help parents see you as that partner. Our goal is to work with parents in all stages and help them navigate how to reach long-term recovery while sustaining their children in their home when it's possible to do so. It's important to note here that there may be a lot of different agencies working with families, and a coordinated, collaborative approach will enhance opportunities for engagement and help families see that everyone is working with them instead of against them. So how do we identify signs of potential substance use? Well, this list is not inclusive. Here are some examples of potential signs of use. These are good things to watch for so you can address problems before they escalate, or potentially collaborate with families to create safety plans that allow children to stay in the home with their parents. So take a moment, I'm going to pause, but take a moment to read this list and think about any other potential signs of misuse. Have we missed anything here? So addressing these potential signs of use should be done in a non-threatening way. And this extends to everybody who's working with families. Even though these conversations are very difficult to have, there's opportunity to engage with parents so they're willing to seek out treatment and services and participate in safety planning. Remember that just one of these potential signs of use may not necessarily indicate that there's a problem. When we assess parents for substance use, we want to examine the full picture, and we don't want to jump to conclusions based on one or two observations that could have different root causes. So as we've moved to home-based services across the country, lots of information can be gained through evaluation and observation of the home environment. So if you're a child welfare worker, if you're a home-based worker, or maybe you're training staff for these roles, you probably are familiar with the short list of factors to look for in the home environment when you're working with families who are using substances. So unsafe home conditions. These are sometimes, but not always, a good indication that something isn't going right in that family home. So if you're working with a family on an ongoing basis, pay close attention to changes in home conditions, as this could be an indicator of return to use. As you assess home environment, remember that this alone is not an indicator of substance use. So consider what we can do to support families. Can you help families identify somebody to support them to remedy an unsafe situation? Do you need to connect them with a more formal provider to help solve the problem? Assessing home environments for safety hazards and drug paraphernalia during every contact is also very important. So encouraging transparency through engagement and that relationship building can help you identify what you might be looking for, and will hopefully encourage parents to tell you if they're actively using. While we ideally want parents to abstain from substance use, a harm reduction method might be required based on specific circumstances of the family. So discussing safe storage of all substances, including medical cannabis, prescription medications, alcohol, and medication for opioid use disorders, such as methadone and Suboxone, is crucial to ensuring child safety. We know that families have substances in their home, and helping them ensure children don't find, touch, or consume them, and checking on safe storage measures with every home visit you make can prevent serious harm. And finally, evaluation and observation of the home environment should always include assurance that children under the age of 1 have a safe sleep arrangement. Since we know parents with substance use can impair their functioning and maybe cause sleepiness, it's crucial that infants and babies have sleeping space where they're alone, they're on their back, and they're in a crib. So let's talk a little bit more about what we're seeing in terms of parental substance use. We've recently heard from states around the country about increases in accidental ingestion, specifically in the forms of fentanyl and edible cannabis products. So limiting access to substances that can harm children is a crucial step to helping families ensure child safety. As products are developed that look, taste, and smell like sweet drinks, like candy and gum, they may look appealing to children and have very, very serious consequences. Many states who have recently legalized cannabis recognize that access to substances will increase, and these substances may be appealing to children and youth. We've also seen an increase in fentanyl-laced substances, especially those that are obtained illegally. So knowing what you have in your home and where it came from can reduce incidents of accidental overdose. Prescription medication in the home is another concern. We know that many youth have their very first experiences with drugs by finding prescription medication in their own home. Child welfare assesses safety issues in the environment, but all systems working together with families should be reviewing concerns with parents. I've spoken a little bit already about safe storage of medications and strongly encourage that dialogue about safe storage during contact with families. So consider what your community offers to help families with safe storage. Can they receive free lockboxes? Are there drug take-back programs that properly dispose of prescription medication? Or is this something that your agency can offer? In addition to ensuring substances are locked and stored in safe places, make sure parents are aware of risk associated with substances in their home, and they have phone numbers for the Poison Help Hotline in case of ingestion. Having conversations with parents about identifying when to call 911, what signs to look for in case of child ingestion is also important. There are numerous online resources available that offer one-pagers and short videos about reducing the risk of child ingestion. Also, as providers talk with parents about where they'll store these important phone numbers. Is it in their phone, on the refrigerator? Do older children in the home or other caregivers who might watch younger children have access to that information? And does the parent know how to identify if a situation requires emergency assistance versus a call to the Poison Help Hotline to discuss next steps? While we know it might be really hard for parents to be honest if their child ingests something, it's extremely important that parents give clear and accurate information to the Poison Helpline or medical personnel in the case of child ingestion. Engaging with parents and encouraging that transparency and honesty will help them practice that same behavior with other professionals.
It's also important to think about how we're keeping parents and young adults safe, particularly as the number of overdoses continues to rise across the country. All systems working with families need to understand the risk of overdose and steps that can be taken to reduce the risk. There are several factors that can increase a person's risk of overdosing. Changes in tolerance from not using or using less can increase somebody's risk. This happens after a parent has been in inpatient treatment, incarcerated, or following a period of less or no use, such as being in early recovery. We know there's changes in the drug supply. Everyone is aware of the challenges states are facing with fentanyl today. Mixing opioids with respiratory depressants or stimulants can increase a person's risk, as can having another chronic health condition such as HIV, hepatitis C, lung disease, heart disease, or other health concerns. We know that people who have past overdoses have a higher risk of a future overdose. Understanding the parent's risks of overdose and coordinating and sharing information across systems with appropriate processes in place that facilitate sharing of information can help all professionals work to better understand family safety and support recovery. Having staff across the systems that serve families be informed about strategies to prevent overdose increases the likelihood of positive family outcomes. Talking at team meetings or case staffing about managing overdose risk and how to prevent overdose makes everyone aware of the concerns and how to work together. We know that access to treatment is important, particularly when the person needs treatment and when they're ready to engage in treatment. When treat is not available, their risk increase. Access to naloxone, commonly referred to as Narcan, is another strategy to address overdose risks. Having family members aware of the availability of naloxone in their community, encouraging them to get trained in administering it can save lives. Many states have public health campaigns, Good Samaritan laws, and programs that distribute naloxone. SAMHSA has also produced an opiate overdose prevention toolkit, and we encourage all of you to be familiar with your local resources. There are tools and strategies that can help prevent overdose. What needs to happen next is for people to come together to understand the risks and how we work together to address those risks. Knowing how parental substance use disorder affects a parent's ability to safely parent is something all providers and systems need to understand.
So what do we see in child welfare cases involving parental substance use? Parents might experience an emotional disconnection with their children that's caused by a preoccupation with the substance or obtaining that substance, the direct effects of the substance, or the emotional effects of use and withdrawal. This might leave children unsupervised or their general needs not met. Parents might have difficulty providing structure or routine for their children, which can impact their health, nutrition, education, or socialization. Due to the substance use disorder, parents might not get their children to school on time or support schoolwork that needs to be done at home. Also, some children might avoid going to school as they might be worried about their parent or younger siblings at home. We sometimes see challenges with home conditions or difficulty maintaining employment or household expenses. Remember that when child welfare evaluates child safety in cases with parental SUDs, they're looking for that connection between the substance use and the parent's ability to keep their child safe. So while substance use can affect an individual's ability to parent, people with SUDs are not bad parents. In our video series, we spend some time talking about the definitions of safety, risk, and protective capacities. We understand that different states may use different words for safety and risk, and we really encourage you to consult your policy and its corresponding definitions to determine how the content aligns with your state or your jurisdiction. So let's talk about each of these. Safety factors refer to present or impending danger to a child or insufficient caregiver protective capacities to ensure a child is protected from danger. Safety factors could result in serious harm to a child, and they're immediate problems that need to be resolved to protect a child or prevent further harm. In other words, safety threats happen at a very specific point in time, and child welfare has to act quickly to remedy them. Risk factors refer to the likelihood of future maltreatment. Often risk factors aren't observable at the onset of involvement, but they come forward as we get to know families better and we explore what's happening within their family unit. Risk often occurs on a continuum of low to high. Caregiver protective capacities refer to the personal and parenting behavioral, cognitive, and emotional characteristics that can specifically and directly be associated with the person being protective of their child. So these are qualities that we can see, we understand, and that parents demonstrate as part of the way they think, they feel, and they act that makes them protective of their children. So this is about a parent's ability to act on behalf of their child to ensure their current and ongoing safety. Protective factors are defined as these 6 listed factors that strengthen families: parental resilience, nurturing and attachment, social connections, knowledge of parenting and child development, concrete supports, and social emotional competencies of children. We aren't going to review these in depth today, but the 6 protective factors come from the Protective Factors Framework, which can be easily located on the Child Welfare Information Gateway website. Understanding these definitions is a really important part of our work with families and helps us identify the needs of families and corresponding plans and interventions to address parental substance use and keep children safe. These definitions and corresponding examples are more thoroughly explored in our tip sheets and our video series. Most states and jurisdictions have risk and safety assessments that are utilized as part of their child welfare intervention. Universal standard screening at the beginning of an intervention is extremely important to reduce disproportionality. Using that same screening questions for all parents to determine risk and safety helps workers reduce that likelihood of personal or agency bias, and it provides a holistic and fair assessment of the family situation. From here, child welfare, treatment, and the courts can work together to help the family develop culturally responsive case plans and services. So if you aren't familiar with your state safety and risk assessment tools, take a look at policy or talk with your child welfare partners for more information. Safety and risk can't be fully assessed without considering the totality of the family situation. So this includes specific factors that happen within the child and within their environment. So here are a few things to consider when you're assessing the safety of a child when there's parental substance use. First is the age of the child. So Kim talked a little bit about this when she shared some of the AFCAR's heat maps, but we know that young children are more dependent on their parents to meet basic needs. For infants and for very young children, there's a total reliance on their parent, as young children have no capacity to protect themselves. Older children may have more of an ability to keep themselves safe, and they can communicate with others and get help if they need to. But each developmental stage presents a challenge related to parental SUDs and should be considered. For example, with infants, we might be concerned about a parent falling asleep while holding their infant, or unsafe sleep practices when that parent is in active use. For toddlers, we might be concerned about paraphernalia in the home or access to those substances they might ingest or put in their mouth. As children get older and rely less and less on their parents to meet those very basic needs, acute safety threats might lessen, but we could see youth potentially getting involved in substance use themselves. Now let's talk about child visibility. Children that are visible in the community, those that are going to school, attending childcare, going to their doctor's appointments regularly, or they're involved in community activities, can be seen and observed, and this enhances safety. It allows children to report safety threats to a caring adult if they want to do so, and it allows caring adults to watch for risk factors or threats of harm. Next, it's important to consider the unique needs of the children in the home. Children with developmental or physical disabilities may be more at risk due to those higher needs that their parents have to respond to on a daily basis. So it's important to consider the child's development, their potential diagnosis, and their awareness and understanding of what's happening around them when we consider the severity of safety threats and of risk. Finally, we should observe the parent and child interaction as part of our ongoing assessment process. Is the parent responsive to their child? Does the child go to that parent for comfort or for advice? Have we taken time to learn about that family's culture and how this influences parent-child interactions? Staying attuned with the parent-child relationship can help us identify more subtle threats of harm and eventually can be part of safety planning and improving protective capacities within the family. So speaking of those protective capacities, why is it so important that we talk about protective capacities as we define safety and risk factors? Typically, families affected by parental SUDs are experiencing challenges within their family unit, and child welfare's charge is to address those safety factors, mitigate the risk factors, and help families achieve safety, well-being, and permanency so they don't return to the system again. An important and often forgotten part of assessing conditions in the family is also examining their strengths and their protective capacities. This isn't only about how to mitigate risks, but it's about how we engage with families to honor their strength and their resiliency. So when we take that time to recognize parental capacity and to share our positive observations with families, we build trust and we help families bolster those positive attributes, which help them become more protective of their children. So we're now going to take a look at another clip from our webinar series, and this highlights strategies to developing protective capacities that are very specific to parental substance use disorder and recovery.
In SUD cases, we take this a step further and look at the parents' action steps to help us understand their overall protective capacity. So here are a few other things to consider. Think about, does the parent admit their need for SUD treatment or other services? We feel better about child safety if parents recognize they have a problem and are willing to seek treatment to address their SUD. Along with this, when a parent is remorseful for the effects of their action and they have insight into how their behavior may impact child safety, it's easier to develop plans with the family. From a caseworker point of view, helping the parent access treatment quickly allows them to have more contact with professionals that support recovery and help them develop coping skills. When parents consistently attend treatment sessions and demonstrate active engagement in treatment, they're progressing on case plan goals and they're moving towards case closure. A concrete form of support for families with SUDs is when family or friends are willing to do check-ins and help monitor child safety. A supportive caregiver in the home while a parent seeks treatment not only supports child safety, but helps parents build their informal support network so they don't return to the child welfare system after case closure. Connecting parents to daycare for the child for a portion of the day also helps assure safety and encourages social and educational development while allowing parents to attend treatment. All of these things help us feel better about children staying in the home with the parents and caregivers.
So a lot of these examples you heard in that video clip sound like case plan and treatment goals, but if you really think about it, each of these strategies and action steps promote building of protective capacities and strengthening of families.
But we don't do this work alone. Collaboration across systems and providers improves outcomes for families. As we highlighted at the beginning of the presentation, parental substance use disorders are a factor in a majority of child welfare cases. When child welfare is making decisions around safety, risk, and identifying protective factors, mitigating the risk of parents' substance use disorder is critical. This requires systems to come together. It isn't easy to know where to start when building your collaborations that will have meaningful outcomes for families. The National Center developed the Building Collaborative Capacity series in 2021 to provide states and communities the strategies to create cross-systems collaborative teams, communication protocols, and practice innovations. These strategies aim to improve screening, assessment, and engagement to best serve families affected by substance use disorder and child welfare service involvement. We're dropping a link to this in the chat now. Collaboration takes time and effort. Knowing the different roles each system has and establishing common language can support these collaboration efforts. Research shows us that forming these relationships results in better outcomes for children and families involved in the child welfare system. Collaborating with treatment and other service professionals to sustain and strengthen family relationships leads to a better understanding of the families and the challenges they're facing, better planning, and more effective monitoring. Collaboration is not a one-time event. It needs to happen with various systems and in all different levels that work with families. Treatment providers, courts, child welfare, healthcare professionals, and other providers are serving the same families, but the work is often not coordinated. Sometimes systems are not even aware that other providers are working with the same families they are serving. Identifying all the systems involved as soon as possible when working with the family and what their expectations are is one of the initial steps towards collaboration. This helps to coordinate efforts, understand the work that each system or provider is doing with the family, and can reduce duplication of services. How often have you worked with a family where child welfare is asking for a drug test? The treatment provider is doing drug testing as part of treatment, and the courts also have this as a requirement. How do we think about coordinating and sharing information so there isn't duplication and families see their providers working as a team? At the case level, there are several opportunities to enhance collaboration efforts, such as family team meetings, which allow families to have a voice in their own case planning. Using collateral contacts and case staffing opportunities to enhance our understanding of families, challenges, and progress that will help us inform next steps. When collaboration happens at the system level, it will inform how professionals work together at the case level. Formalizing collaborative opportunities between partners sets up the expectations of how we work together, not the exceptions. When systems come together and identify the ways they work together, families can see how they work in partnership. Think about the multidisciplinary meetings that you have in your different systems and communities. Where is the room at your table to bring in other partners? Coming together provides an opportunity to talk about each system's role with the family, identify how information will be shared, and how you can coordinate the expectation of families to maximize services and reduce duplication. We know that every community is different, and you have to identify where those collaborative opportunities exist, remembering that it takes time to build relationships with your partners to determine how to best work together. When we work with parents, we want to make sure we create an environment that is welcoming and receptive to where the parent and family is in their process. To create this environment, parents need to be part of the process, determining how and what information is being shared between systems and providers, how that information might be used, and who it will be shared with. Families need to be encouraged to bring their supports to the table so they can feel comfortable participating. It can be intimidating for a parent to come to a team meeting, and having a support person with them can be helpful. Appropriate release of information must be in place for ongoing communication. Having regular communication is paramount, as is sharing information at critical case decisions and changes with the family. Determining how often you share what information will be important. Coordinating between systems requires a lot of communication and collaboration. Clear patterns of communication and an understanding of who needs to know what and when sets expectations for communication. Finding the balance of sharing the necessary information for all systems to be informed while respecting the confidential information we hold is something you need to work with your partners on. There are differences in how various professionals are viewing and treating the family. We all have our own unique lens to share. One of the most effective ways to get everyone on the same page is to form an individualized family team that includes everyone working with the family and the family's own voice. This provides an opportunity for everyone to understand what information will be shared. Let's hear our last two clips about the types of information that should be shared between systems to be helpful.
As child welfare workers, it's crucial that we have as much information as possible about parents' treatment. Child welfare should know how a parent is doing in treatment, although they don't need to know specific clinical details. This list here includes the types of information that treatment professionals can share with child welfare and court personnel. While it's important to know if parents are attending treatment as recommended, it's also important to know if they're participating and progressing in treatment. Think about what information you need to know from treatment providers as you prepare for case staffings with your supervisor or write court reports. What information do you need to support recommendations and decisions about case progression? Some of these items can be provided to you through written reports, but others are more urgent in nature and potentially impact child safety. If a parent leaves treatment, has a positive drug test result, or returns to active use, it's crucial that providers contact you immediately so you can pull together your family team and discuss next steps. Good working relationships with treatment providers will allow you to set expectations for timely communication in times of crisis. So think about how you currently communicate with treatment providers, if you consistently receive information, and how you can potentially make improvements. While we need good information from treatment providers, remember that treatment providers need good information from child welfare too to effectively serve parents or a family. Sharing information with treatment starts at that initial referral for an SUD assessment. The more information a treatment provider has about the family situation, the more effectively they can diagnose and recommend an appropriate level of care. Remember that we often work with parents who aren't quite ready to change, and they may not be open about their use during that initial SUD assessment. So early information gives treatment providers a fuller picture of the parent and the ongoing concerns. Take a look at this list and think about whether you consistently provide this information to treatment providers upon referral. Information sharing should continue after parents engage in treatment too. The stress and complexity of a child welfare case will have a considerable impact on the parent's emotional functioning. So keeping treatment providers up to speed on case progression will allow them to understand parental behavior and hopefully help them avoid a return to use episode. Since we're always thinking about parental engagement, be sure to let families know that you're communicating with their treatment providers. While this may make families feel uncomfortable, assure them that you aren't giving clinical details and you aren't receiving that information or asking it from treatment. But you do need to understand engagement and progress to help families reach their goals.
When you sit down with your partners, be specific about what types of information is important to share and discuss how you'll talk to parents about this when they're signing their release of information forms. Developing administration policies and protocols to enhance cross-system communication is particularly critical when the information to be shared is considered confidential by one or more of the systems. Systems operate within strict federal, state, and local guidelines regarding how information about families may be shared, and families have the legal and ethical right to trust that information about them will be kept private. Guidance for sharing this information must conform to federal government regulations, such as 42 CFR Part 2 and the Health Insurance Portability and Accountability Act, also known as HIPAA. HIPAA strikes a balance that permits important uses of information while protecting the privacy of people who seek care. 42 CFR Part 2 is for substance use disorder treatment information and states that most disclosures are permissible if the client has a signed, valid consent form that has not expired or been revoked. Sharing of information can often be highlighted as a barrier of working together. In order to build trust, you need to come to some agreements across systems, including how you're going to communicate. Leadership in each system can work to agree on common values, share data outcomes, and how services can be supported through various funding streams. In the end, enhanced collaboration benefits the families we're servicing. Getting and retaining parents in treatment, having fewer children enter out-of-home care, or reunifying them more quickly with their families are outcomes that we can all agree benefit the whole family. We have covered a lot of information today that we hope is helpful in thinking about your next steps. After this webinar, what is one thing you can think to do next when you return to your community? What's going well that you can build on, and where are there areas for improvement? We have time for a few questions, and any questions that we don't get to now, we can follow up with you after the webinar.
Thank you, Kim and Elizabeth, for that presentation. With the time left, we're going to move into the Q&A. And the first question is for you, Elizabeth. Can you talk more about safety planning around the use of cannabis by caregivers? For example, the use of cannabis at night when children are sleeping.
Yeah, so since cannabis remains illegal at the federal level, but states vary from full legal recreational use to only medicinal use to being illegal, cannabis remains a really complicated subject for family serving systems. If parents are transparent about their use, safety planning should include conversations about safe storage, about abstaining from use in the presence of children. So those honest conversations with parents and supports about how cannabis affects their functioning is really going to be crucial to those safety planning efforts. So are they using it for medicinal purposes, or are they finding that the use is affecting their functioning in daily life? Using those universal standardized screening tools, so some examples, maybe the UNCOPE or the GAIN, can help you assess if parents are potentially misusing cannabis. And that then informs that safety plan. And then I'd say, regardless of legality and whether or not someone has an SUD, there should always be a caregiver available for children who's not under the influence of any substances. So child welfare would assess any safety or risk concern, regardless of the legality of a substance.
Thanks, Elizabeth. The next question is for you, Kim. How can other agencies other than child welfare assess parents' capabilities to care for their children, as well as assessing the environment?
Well, as we've talked today, child welfare agencies have very specific safety and risk assessment tools, policies, practices in place to formally assess safety and risk. They have specialized training for their staff and how they approach their assessment and gather information. Other agencies shouldn't try to replace the role of child welfare and make a determination about safety and risk independently. That said, we're all responsible to ask further questions to get a better understanding of each family's situation and share that information through ongoing communication with child welfare professionals, or if it's a reportable condition, to make that report to child welfare. Treatment providers should be asking adults if they have children and what the living situation is at home. It's important to normalize asking these questions about children and the living situations to all adults, as we don't want to create further disparities in the systems. Sit down with your child welfare partners to understand their processes and how to best support their work with families, and share the necessary information.
Thanks, Kim. And I'll pose one last question to both of you. What role do you see peer support playing in this mitigation process?
Oh, great question. So we know that many fields across the country are now incorporating peer support into work with individuals and families. And peers tend to have great success with engagement as they offer that lived expertise that really resonates with individuals and families. So in my work with peers, I found that parents are sometimes more willing to talk openly about their use, and they feel more comfortable sharing if they have a return to use episode with those peers. So when peers are integrated into our system and part of collaborative process, some of the things that Kim and I talked about today, they really are essential to that building of trust in relationships between parents and child welfare and the courts and other providers. So while peers might not be specifically assessing safety and risk, right, in the formal way that child welfare does, their relationships with clients afford them with that opportunity to see maybe more than what other professionals might be able to see in their role.
Well, and I think a natural place to include peer supports is during family team meetings. It can be really intimidating for parents to attend a meeting that has a room full of professionals. Peers can provide that support and education to the parent and help the parent find their voice so they can contribute to the process. Think about what your agency is doing to build relationship with peers. Do you have them as part of your systems? Can you identify new ways to partner with peers to improve outcomes for families?
Thank you, Kim and Elizabeth. And with that, I would once again like to thank both of you for a wonderful presentation and to all of you for attending.